Welcome everybody to another episode of Coffee with ADHD Experts. This innovative series brings together some of the most eminent experts in ADHD and mental health in the world. We know that demands on mental health services are rising. We know that this increase can never be met by professionals alone. So the question is, how do we think differently about mental health? What do we have to change? You are welcome to join us to enjoy this collective experience on ADHD across the lifespan. We will be sharing 3 short questions that we can enhance our purpose as advocates and let another mental health professional have the chance to listen to their experiences. Let me introduce to you who we are. Norma Echavarria is my name. I'm MD, medical psychiatrist, adult psychiatrist, president of the ADHD chapter of AAP in Argentina, American Psychiatric Association International Fellow, World ADHD Federation member, and American Hispanic Psychiatric Association member. And my partner, Eleonora Giusti, that sadly she's not able to be here today. She's a PhD psychologist, vice president of ADHD chapter AAP in Argentina, clinical psychologist and family therapist, professor at Palermo University in Buenos Aires, Argentina, and Argentina Association of Cognitive Therapy member. And now I will introduce all of you to our guest today, Dr. Russell Schachar. It's a long video. I'm going to take all this time because your career is an amazing thing, and we are so glad to have you here, Russ. So Dr. Russell Schachar is a practicing child and adolescent psychiatry, professor in the Department of Psychiatry at the University of Toronto, and senior scientist in the Research Institute at the Hospital for Sick Children in Toronto, Canada, where he holds the TD Bank Chair in Child and Adolescent Psychiatry and heads a cognitive neuroscience laboratory which focuses on psychiatry disorders of childhood and adolescence. Current project focus on the genetic and environmental influences on cognition and ADHD traits in the general population, the genetics of ADHD, OCD, and ASD, the neural basis of executive control and physicopathology through functional neuroimaging studies, and the cognitive and behavioral consequences of treatment for acute lymphoblastic leukemia. He graduated as MD at Toronto University in 1971. He developed roles as lecturer, research fellowship, then was a research fellowship in the Department of Child and Adolescent Psychiatry Institute of London, England, research training fellowship in Ontario Mental Health Foundation, fellowship Medical Research Council of Canada, research associate Institute of Psychiatry in London, England, assistant professor, Department of Psychiatry in the University of Toronto, faculty graduate, Faculty of Education, University of Toronto, senior research fellowship, Ontario Mental Health Foundation, Institute of Medical Science, University of Toronto, Senior Scientist Research Institute Hospital for Sick Children, Toronto. Don't get tired, it keeps moving. Associate Professor, Department of Psychiatry in University of Toronto, Director of the Child Psychiatry Research Fellowship, Division of Child Psychiatry, Department of Psychiatry, University of Toronto. Alain Lewis Award, American Academy of Child Adolescent Psychiatry, is a professor of the Department of Psychiatry, University of Toronto, TD Bank Financial Group Chair in Child and Adolescent Psychiatry that was renewed in 2015. Had Chad Hall of Fame Award, recipient of the Schwartz Reisman Travel Award, and contributions to science, discovery of cognitive biomarkers and the phenotypes of ADHD, genetics and ADHD, functional imaging of executive function, and wow, that is a bio. Let's welcome enough. Our friend, Dr. Russell Schachar. So we're so glad to have you here, Russ.
It's a pleasure. It's a pleasure, and thank you, Norma and Eleonora, for your generous invitation. It's a delight to join my colleagues in Argentina. Hola.
Oh, it's so great to have you. You will be back And maybe we will go to tango. That's a good
Yes.
thing to do.
Yes.
Right? I know you love that from our country. So the first question for Dr. Russell Schachar today is about like the past is as a researcher, psychology, doctor, teacher, advocate, you have so many of those things in your daily basis and been one of the main references in this field. What has led you to work with the ADHD population? And then how did your interventions make a difference? So that would be our first question for you.
Right. Well, that like all psychiatrists and mental health people, we tend to be interested in history in the past. There's an overt and a covert reason why I got interested in ADHD. Overtly, I was interested in studying something and learning more about something that was quite novel. I've been interested in ADHD since the time I was a resident in child and adolescent psychiatry. And I was very interested in the role that cognition played, thinking, feeling, and action at a basic science level played in psychopathology. And I was inspired by people who are working with children who are at high risk for schizophrenia by virtue of having one or two parents with a diagnosis of schizophrenia. And I was struck by the fact that those children often presented with ADHD. And that was really where I started my career, asking about ADHD, which was not even called ADHD at the time, and very hardly studied at all and poorly understood. But the covert, probably the covert, there were covert motivation for studying ADHD was probably twofold. One was that I, even as a resident, was feeling very uncomfortable with psychiatry. I was a trainee and I was, I guess, deeply disappointed in how poor our understanding was of the problems that the children presented and how ineffective our treatments were. And it bothered me deeply. And I felt that, there were many ways forward. One way to be through a better scientific understanding of the problems that we were dealing with. So early on, I made a clear decision that I would identify more with the scientists than with the practitioners. And I think I've been, for rightly or wrongly, I have pursued that path throughout. And what was the second part of that first question, Norma?
What was the difference that you feel you made since you were involved in that area?
Well, there have been hundreds of, when I started, actually, you could probably count on one or two hands the number of people who are interested in ADHD, Keith Connors, Eric Taylor, and I mean, there were, Russell Barkley, there were just a handful of people. But now, thank goodness, there are hundreds and hundreds of people who are interested in ADHD at every level, from genetic, neuroimaging to clinical practice, developing new interventions. So it's both arrogant and difficult to talk about one's own contributions. I think that we all worked collectively to lead us to the point where people less and less, but less and less saying that this thing doesn't exist, that it has no scientific basis, that that it's overdiagnosed, that nobody knows how to die, et cetera, et cetera. We've all contributed to changing that entire landscape. I think my unique contribution has been on the cognitive side, meaning that people like Joe Sargent and I think were the earliest people to take cognition and psychopathology in ADHD very seriously and produce, systematic bodies of research in that area. But nobody is unique and nobody develops, discovers anything, especially these days, without a large number of collaborations.
Well, but I think that being somebody that read many, I cannot say every paper you have because there are so many, but I would say that your contribution also is keep yourself motivated to keep research going on. It's not only genetics, not only all the cognitive, it's keeping there while things are
people have
tough.
said, don't you get bored? Don't you get bored with ADHD? And I say, well, actually, I've not been bored with ADHD. I mean, I've written papers on the social history of ADHD and spent a considerable period of time trying to research using historical records the earliest reports of something that would these days be called ADHD, and try to understand the historical context. So I've taken a social historical perspective and a genetic and a neuroimaging perspective. So I don't get bored. I think you can see all of child psychopathology through the lens of ADHD.
Yes, that's so cool. Well, let's go through the other question. I know you made a lot of differences, but you're just too humble to say it. Now let's say that what have you achieved getting actively involved in this field? Not make the difference, what you achieved as a person, as a professional, what you achieved? And did you find cultural, social, gender, or age barriers on that path? It's what you achieved,
yes.
and what did you have there?
Okay. So I don't know, what did I achieve? I think mostly what I did was I managed to stay happily engaged in child and youth psychiatry for multiple decades without becoming depressed or disillusioned. And so I'm taking a very personal, what did I achieve? I did a lot for myself. I mean, I know that may not have been the intent of the question, but I think my colleagues who work day to day, 10 hours, 12 hours a day, seeing one patient after another without hardly an opportunity to take a breath, they're the real heroes in this field. I could not have done that because I don't think I had what it takes to do that. And taking an academic approach allowed me a little bit of distance and allowed me to make those other contributions, let's say to cognition, to help train people, help develop programs, collaborations, get research projects going, some of which have generated interesting results. And by the way, not always in ADHD. I mean, I think some of our most novel research results from the projects that I've started have been in OCD, just because we have looked at multiple disorders at the same time. With respect to barriers, I think that they are obvious and many. And you notice them even in Canada, which is a first world country where theoretically mental health services are readily available, and we have a first world healthcare system where with the government as a third party payer, so it's even more sophisticated than it's more European than American. Yet we still see, and by the way, Toronto, for example, is a fabulous laboratory for cultural studies because it's one of the most ethnically diverse cities in the world these days. So there are large segments of the local community are South Asian, East Asian, Hispanic. Now, not at all what you might expect, and you notice in these communities one thing you notice is that traits are prevalent throughout, but different communities pursue diagnoses and children get treated, and in other communities they don't. The age issue is been well studied and well understood, that that if you manage to make it into adolescence or adulthood without a diagnosis of ADHD, it's very difficult to get a diagnosis in later life. Our adult colleagues in psychiatry don't have much respect for the diagnosis, even though it is clearly demonstrable that it plays a huge role in risk for psychopathology of all kinds, depression, suicide, to just all sorts of kinds of impairment. There are still outstanding gender and sex differences in psychopathology of all kinds, but ADHD in general. So you do see these, we're now trying to understand more of the cultural differences as part of our active research. But you have to, it's very complicated.
It's hard, it's complicated, of course.
There are biological differences because, genetically, our ancestry does matter in at least in discovery of genetic risks, and our ethnicity matters socially. So we don't live in a world. We don't live in a world where everybody has equality of opportunity or housing or resources or whatever. So these factors make it extremely complicated, also politically loaded. Right.
Yes.
It's very easy.
We are very much concerned because in Argentina and South America, we do have those bias about not only mental health, that's a big thing, but also about diagnosis and diagnosing kids and all that stuff about treatment, right? So we do want to just put all those barriers down. That's why we're doing this. So thanks again. And here is the last question, but not less important. On which step from the way through your ADHD road would you say you are today? It's a long road, right? But you're still there. And what do you imagine the ADHD field to be like in the future?
Well, I think that the greatest leverage in understanding ADHD right now comes from two sources. Interesting. One is obvious and one I think is less obvious. The obvious one is genetics. I think that we have clearly understood that now that common and rare variants contribute to ADHD both as a trait and as a disorder. And now the exercise is to pursue that in the future till we can reach the point of saturation, meaning we've identified as many variants and combinations of variants that contribute to ADHD as possible. And I think that that is where the greatest leverage comes from. The other, in terms of understanding, the other source of understanding comes from every place where you find ADHD outside of ADHD. So concussion, medically ill, neurologically ill, people who are going to suffer the long-term consequences of COVID will present with ADHD, attention, learning, and behavior problems, et cetera, et cetera. I think that will afford another, those are awful natural experiments that will teach us more about how biology and stress affect the developing brain and manifest as ADHD. The future, I think, will involve a lot more personalized medicine, but that's a dream, and I think it's good to have a dream like that. In the short term, we have a ton of work to do just to make services available, to make them comprehensive, to open up opportunities for drug use in some communities where it's frowned upon or discouraged or not even not allowed, which is unfortunate because this is not a political act, it's a medical act. Medicine is not a pretty business. Our job is to improve the lives of children, and medication for ADHD certainly does. But it's not the whole story, and it's far from the whole story. And if you're not going to provide medication, then you better be providing intensive non-medical interventions that are multidimensional and long-term, because there's no evidence that quick and dirty, 5 sessions of parent training.
No, it's going to be covering what that means. That's great. And you were going, remember, I think that pandemic, COVID, just did not allow you to come to VA, and we were going to do a presentation together, and you were going to talk about the impact of ADHD. Remember, that was a beautiful topic, and we were talking with Dr. Russell Bartley the other day about longevity and how it's a serious health, like public health problem. It's not just a mental health problem. Do you want to say something about that?
Well, I mean, there are now multiple studies that point in the same direction, which is that even if you take away obvious issues such as accidents, because it's clear, I've done a lot of head injury research. It's clear that ADHD is, let's say, at the highest prevalence estimate is about 5%, let's say, but 20 or more percent, all the way up to 50% of children who have a concussion have had ADHD before their presentation. By the way, it's true for burns as well. Children who get burned.
Domestic accident mostly, right?
Exactly. So, but even if you take away all of those obvious things, it turns out that the care of the health of ADHD individuals is severely impacted, and it so much so that their longevity, they have a shorter lifespan. That's a serious marker of as yet not well explained processes. But clearly one of them is, some of them are lifestyle issues, that if you smoke, ADHD folks, people smoke,
obesity,
variety of different risk factors. But there's probably shared genetic risk with medical problems, because that's just how complicated the humanity is, that medical and mental health issues may arise, and frequently do, from common risk factors, whether it's stress, which is obvious to us, or genetics, which is maybe less obvious. Why you should have ADHD and, let's say, heart disease from a common genetic risk. But it seems increasingly plausible that that's true.
So you're never going to be retiring, Russ. You're working on this. Novel issues constantly triggering your curiosity, right?
Well, I must say that I'm very curious. I'm a bit like a crow or a raven, I chase shiny objects. So, but ADHD keeps giving lots of opportunity for that.
Well, and the last thing is, we're so grateful for your time, your generosity, for being here. And what would be, it's like, just imagine people are watching this, what would be your take-home message? Would be the phrase, the strong message? It's like something powerful you want to say to people, families and professionals from all over the world in this Hispanic community?
I would just say that retain your sense of conviction, communicate that to your families, help them understand their problems, and help them get the right balance between self-blame and understanding. The people who work with children who are affected with any mental illness are really doing God's work every day, whether they're scientists and never see a patient, or whether they're clinicians and never go into a
An
laboratory.
amazing message. I think that I am one of the doctors in my adult psychiatry that see patients and I see the suffering. But I also say if we can do an earlier diagnosis, an earlier approach to families, it's not just the kids are suffering, their whole family suffers because they perceive themselves as responsible of being failed as parents. And then there's a lot of suffering in families with ADHD and the surroundings, right? So that was an amazing message for us to receive from you, Russell. Again and again, I will say
thank you for inviting me. I'll end by showing you.
Oh my God, isn't that a gorgeous yard? My love.
Well, that's the lake. We have a house on the lake, and it's full of birds, ducks migrating.
That's an amazing
springtime in Toronto.
Springtime, yes, and all the cherry blossom trees. Do you have them or not?
Yes, we do.
That's an amazing. So hoping to see you here or maybe meeting someplace. Thank you very much. We respect so much and thank for all the community, all the work you've done for so many years.
A pleasure.
So,
thank you for inviting me.
No, thank you. Bye-bye. Bye.